Welcome back to the Deep Dive. Today, we're doing something a little different. We're not just exploring a topic. We're trying to simulate a very specific moment.
A very stressful moment.
A very stressful one.
Yeah.
I want you to just imagine, for a second, you're standing outside that exam hall. You know the one. The air is cold, your hands are a bit clammy, and you're about to walk in for your MD Anesthesiology finals.
The Gujarat University Viva. I remember it well.
Exactly. And inside, that senior examiner is waiting. He's seen it all. And the topic he picks from the bowl is adrenal diseases.
Ah, a classic. A real kingmaker of a topic.
It seems like it. I mean, looking at the books we have here, Barash, Miller, Yao, and Artuzio, these two tiny glands on top of the kidneys are, well, they seem to be at the center of everything we do.
That's not an overstatement. I always say the adrenal gland is the engine of the stress response. Without it, or if it's malfunctioning, a patient simply cannot survive the controlled trauma of surgery and anesthesia.
So this is it. This is your final prep session. You're the candidate. I'm here with the questions, and we have our senior faculty to guide us through.
And just to be clear, I'm playing the part of that examiner. I'm not looking for simple definitions. I want the deep physiological reasoning. That's how you pass the MD.
I think that's why examiners love this topic, right? It connects everything.
Everything. Hemodynamics, the difficult airway, fluid and electrolyte balance, pharmacology.
Yeah.
It's all here.
So if you were that examiner, how would you frame the question? What are the common patterns we should expect?
It usually comes in one of three flavors. First, the classic 20-mark long case. That's almost always going to be Pheochromocytoma. It's the ultimate hemodynamic puzzle.
Okay.
Second, the short note or a short case. That's where you'll see things like Cushing syndrome, an Addisonian crisis, or maybe a question on perioperative steroid management.
The third.
The Viva voce trap. They'll hit you with a specific question on physiology, like the HPA axis, or a pharmacology question about, say, etomidate effect on the adrenal gland.
All right, let's start where the examiner would. Basic sciences, anatomy and physiology of the adrenal gland.
Good. So tell me about the gland.
Okay, it's retroperitoneal, sits on the superior pole of each kidney. The right is pyramidal, the left is more semilunar, and it's made of two distinct parts, the outer cortex and the inner medulla.
Right. And the cortex is the vast majority of the gland, maybe 80–90%. It has three layers. What's the mnemonic?
GFR.
GFR. Not for the kidney this time, but for the layers. From outside in. Zona glomerulosa, zona fasciculata, and zona reticularis.
And the function mnemonic that goes with that is salt, sugar, sex.
Salt, sugar, sex. But let's go deeper. Zona glomerulosa, salt. What does that mean for us?
That's where mineralocorticoids are made.
Mainly.
Aldosterone. It manages sodium and potassium.
Good. And what controls its release? First Viva trap.
It's tempting to say ACTH from the pituitary.
And that's the trap. It's wrong. ACTH has a very minor permissive role. The primary driver is the renin-angiotensin-aldosterone system, the RAS, and the serum potassium level itself.
So it's the kidney talking to the adrenal gland, not the brain.
Mostly, yes. And this is critical. Aldosterone tells the kidney to hold on to sodium, and water follows, which supports blood volume. And it tells the kidney to get rid of potassium. If you lose this layer, you get hyponatremia, hyperkalemia, and hypotension. A deadly combination.
Okay, moving inward. F for fasciculata. Sugar.
This is the big one, the widest layer. This is where you make your glucocorticoids, cortisol, and this one is controlled by ACTH.
And cortisol is the stress hormone.
It is the stress hormone. It does everything. It increases blood sugar through gluconeogenesis. It's a powerful anti-inflammatory, and this is a key phrase for your exam. It has a permissive effect on catecholamines.
A permissive effect. We'll circle back to that. That sounds important. Let's finish the cortex. R for reticularis, sex.
Correct. It produces androgens. To be blunt, from a purely anesthetic life or death perspective, this is the least critical layer for us. Important for endocrinology, but it's not going to cause a code on induction.
All right, so that's the cortex now. The very center, the medulla.
The medulla is a completely different world. It's not even the same type of tissue embryologically. It's essentially a modified sympathetic ganglion.
So it's part of the nervous system.
Exactly. It doesn't make steroids. It makes catecholamines. About 80% epinephrine, 20% norepinephrine. This is your fight or flight response, your panic button.
And all of this is coordinated by the HPA axis.
The hypothalamic pituitary adrenal axis.
Yes.
The hypothalamus releases CRH, which tells the pituitary to release ACTH, which then tells the adrenal cortex to release cortisol.
And when cortisol levels get high enough, It tells the hypothalamus and pituitary to quiet down.
A classic negative feedback loop. That's the key to homeostasis. And this entire system goes into overdrive during what we call the surgical stress response.
So when the surgeon makes the first incision.
Or even when you perform laryngoscopy. That's a massive stimulus. The brain screams for help, and the adrenals respond by pumping out cortisol and catecholamines. This is a good thing. It's a survival mechanism to maintain blood pressure and deliver glucose to vital organs.
Our job is to walk a tightrope then. Blunt the response so they don't have a hypertensive crisis, but not so much that they can't respond to stress at all.
You've just described the art of anesthesia, and that leads us directly into pathology. What happens when that engine fails? Adrenal insufficiency.
The examiner asks for a classification.
You need to be very structured here. There are 3 types: primary, secondary, and tertiary.
Primary is a problem with the gland itself.
Right. Addison's disease, the factory is broken. Maybe it's an autoimmune attack, maybe it's tuberculosis, maybe a hemorrhage. The point is the gland is destroyed. So you lose everything it makes, both cortisol and aldosterone.
Okay. Secondary.
Secondary is a problem with the pituitary. It's not making ACTH. The factory's fine, but it's not getting any orders.
And tertiary is a step higher, a problem with the hypothalamus not making CRH.
Correct. But there's a huge anesthetic difference between primary and the other 2. Do you remember what controls aldosterone?
The RAAS system from the kidneys, not ACTH.
Exactly. So in secondary or tertiary insufficiency, a brain problem, the aldosterone-producing layer, the glomerulosa, often keeps working just fine.
So their salt and potassium levels might be normal.
They might be. But in primary Addison's, the whole gland is shot. So you lose salt regulation and you lose sugar regulation. Those are the patients who present with the life-threatening hyponatremia and hyperkalemia.
That's a great distinction. Now, what's the most common cause we're likely to see in the operating room? It's probably not classic Addison's.
Not at all. The most common cause is iatrogenic tertiary adrenal insufficiency.
The sleeping tiger.
The sleeping tiger, yes. It's the patient who has been on chronic steroids for something like rheumatoid arthritis, asthma, or an organ transplant.
So they're taking prednisone every day.
And their brain sees all this exogenous steroid and thinks, great, we've got plenty. So it shuts down its own production of CRH and ACTH. The HPA axis goes to sleep. The adrenal glands themselves, without that constant stimulation from ACTH, they start to atrophy.
And the scary part is, the patient might look completely normal preoperatively.
They look fine. Until you give that induction dose of propofol, the stress of surgery hits, the body calls for a cortisol surge, but there's no answer. The sleeping gland doesn't wake up, and the patient just spirals into shock that doesn't respond to anything.
Let's define that term for the exam: refractory shock. You're giving fluids, you're pushing vasopressors like ephedrine or phenylephrine, but the blood pressure just isn't coming up. Why?
This goes back to that permissive effect of cortisol we mentioned. Your vasopressors, your catecholamines, they work by binding to alpha and beta receptors on blood vessels and the heart.
Right.
But those receptors need cortisol to be present to function correctly. Without cortisol, the receptors become desensitized. They're uncoupled. You can flood the system with norepinephrine, but the blood vessel simply won't constrict. It's like trying to turn a key in a lock that's been glued shut.
That is a terrifying thought. So how do we identify these at-risk patients beforehand? What are the clinical signs?
Well, for classic primary Addison's, you've got the hypotension, the electrolyte mess, hyponatremia, hyperkalemia, and hypoglycemia. But there's a very specific physical sign.
The hyperpigmentation.
The hyperpigmentation, a deep bronze-like tan, especially in non-sun exposed areas like the palmar creases or inside the mouth.
And why does it happen?
Because in primary failure, the pituitary is screaming at the broken adrenal gland, pumping out enormous quantities of ACTH to try and get a response. The precursor molecule for ACTH, called POMC, is also the precursor for melanocyte-stimulating hormone.
So high ACTH means high MSH, which means more melanin. A tan.
Exactly. And you won't see that in secondary or tertiary failure because in those cases, ACTH is low.
But for our adrogenic patient, the one on chronic steroids, they won't be tan. They might even look a bit puffy, a bit Cushingoid. So how do we decide if their axis is suppressed? Is there a rule?
There is a general rule of thumb, and you should state this in your answer. You should suspect HPA axis suppression in any patient who has taken a dose equivalent to more than 5 milligrams of prednisone daily for more than 3 weeks within the past year.
That's a pretty wide net.
It is, and it's meant to be. The mantra is, it is far, far safer to give a patient unnecessary stress dose steroids than to withhold them and risk a full-blown adrenal crisis on the table. When in doubt, supplement.
Okay, let's talk about the specific regimen. The examiner asks you for your plan for perioperative steroid supplementation. What are the numbers?
The guidelines have evolved. We've moved away from the old megadoses towards a more physiologic approach. You should stratify it by the degree of surgical stress.
So, minor surgery, like a carpal tunnel release.
For minor surgery, the patient just takes their usual morning dose of steroids. You might give a single extra dose of, say, 25 milligrams of hydrocortisone the but often their own dose is enough.
What about moderate surgery? A laparoscopic cholecystectomy or a hip replacement?
For moderate stress, a good regimen is 50 to 75 milligrams of hydrocortisone IV at induction, and then you can taper it quickly, maybe 25 milligrams every 8 hours for a day, and then stop.
And for major surgery, a cardiac case, a Whipple procedure.
That's where you need full coverage. 100 milligrams of hydrocortisone IV at induction, followed by a continuous infusion of 200 milligrams over 24 hours, or you can give 100 milligrams every 8 hours. You continue this for 24 to 48 hours and then taper as the patient recovers.
And we use hydrocortisone specifically. Why not dexamethasone or methylprednisolone?
Because hydrocortisone is biologically identical to cortisol, it has a perfect 1-to-1 ratio of glucocorticoid to mineralocorticoid activity.
So it fixes the shock and the salt problem at the same time.
Exactly. It covers all your bases.
Okay, what about our anesthetic drug choices? Is there anything we need to avoid in these patients?
Absolutely. The big one, the classic Viva trap, is etomidate.
The examiner says your patient is in shock. Blood pressure is 60/40. You need to induce anesthesia. Etomidate is known for its cardiovascular stability. Is it a good choice?
And the only correct answer is no. That's how you fail the station.
Why? What does it do?
Etomidate is a potent inhibitor of an enzyme called 11-beta-hydroxylase. This enzyme is a critical step in the synthesis of cortisol. A single induction dose of etomidate can knock out adrenal function for up to 24, even 48 hours.
In a healthy patient, that's probably not a big deal.
Right. Their reserve is fine. But in a patient who is already septic or who has pre-existing adrenal suppression, giving etomidate is like pouring gasoline on a fire. You are actively destroying their ability to mount a stress response. You must avoid it.
Let's play out the nightmare scenario. You miss the steroid history in pre-op. The patient is on the table, the surgery is underway, and they suddenly crash. They are in an adrenal crisis. What does that look like?
It's defined by profound circulatory collapse. The hypotension is severe, and it's completely refractory to fluids and vasopressors. You might also see unexplained fever, hypoglycemia, and if they're not fully anesthetized, abdominal pain or altered mental status.
What is the management algorithm? Your priorities in order.
Priority 1, fluids. Resuscitate aggressively. And be specific about the fluid you choose. You should use D5NS dextrose 5% in normal saline.
Why that combination?
Because you are treating two problems at once. The dextrose treats the hypoglycemia, and the normal saline helps correct the hyponatremia and volume deficit.
Okay, fluids are running. What's priority 2?
Hormones. Do not wait for lab results to confirm your suspicion. The moment you suspect adrenal crisis, give 100 milligrams of hydrocortisone as an IV bolus, immediately.
Priority 3.
Vasopressors. But you have to understand, the pressors likely won't start working effectively until the steroid is on board and has had a few minutes to start sensitizing those receptors again.
I've heard some people mention using dexamethasone in a crisis. Is there a role for that?
There is, but it's very specific. The only reason to choose dexamethasone is if the diagnosis is unclear and you want to perform a formal ACTH stimulation test later. Hydrocortisone will be measured in the cortisol assay and give you a false reading. Dexamethasone won't interfere.
So for a diagnostic dilemma in the ICU, maybe delay symptoms, but for code in the OR.
Just give the hydrocortisone. It's the right drug for the job, and it works now.
Understood. Okay, let's completely switch gears. We've covered too little hormone. What about too much? Cushing syndrome.
Chronic excess of glucocorticoids. And again, you must classify it for the examiner. Is it ACTH dependent? That would be a pituitary tumor, which we call Cushing's disease, or an ectopic source, like a small cell lung cancer pumping out ACTH.
Or is it ACTH independent?
Right. An adrenal adenoma or carcinoma that's just churning out cortisol on its own. And of course, the most common cause of all.
Iatrogenic. Us. Giving patients high-dose steroids for other conditions.
Exactly. And the systemic effects of Cushing's are a laundry list of anesthetic concerns.
It really is a multi-system problem.
Yeah.
Let's start with cardiovascular.
They have hypertension from fluid and sodium retention. They often have concentric left ventricular hypertrophy. They are at high risk for congestive heart failure,
Good luck.
hyperglycemia, often full-blown diabetes. They have central obesity with thin arms and legs but a large trunk. Dyslipidemia is also common.
And musculoskeletal. This seems really important for positioning.
It is critical. They have severe osteoporosis. Their bones are brittle. You have to be incredibly gentle when positioning them, or you can cause pathologic fractures. They also have a proximal myopathy. Their muscles are weak, which can have implications for weaning from ventilation.
And then there's the airway.
The Cushing's airway is a classic difficult airway scenario. You need to be prepared.
Let's break down why. You see the patient in pre-op. What are you looking for?
You're looking for the characteristic fat distribution, the moon face, a round plethoric face, which makes getting a good seal with a mask very difficult.
Then the buffalo hump.
And that's not just a cosmetic issue. That large fat pad at the base of the cervicothoracic spine physically prevents you from extending the neck.
So you can't get them into a good sniffing position for laryngoscopy.
You can't. And they often have supraclavicular fat pads as well, which effectively shortens the neck. On top of all that, their tissues are friable and their skin is thin. You can cause bleeding and bruising very easily. You should have your video laryngoscope in the room and ready to go.
So preoperative optimization is key. What are the main goals?
Control the blood pressure, get the blood sugar under control. They may need an insulin infusion, and check the electrolytes.
Why the electrolytes?
Because at very high concentrations, cortisol can start to bind to the mineralocorticoid receptor. It starts to act like aldosterone. So these patients often have hypokalemia and a metabolic alkalosis. Inducing a patient with a potassium of 2.9 is asking for a fatal arrhythmia.
Okay. And during the surgery, what's a major concern?
Infection. They are profoundly immunosuppressed from the high cortisol levels. You need to be meticulous with sterile technique.
There's a paradox with steroids here, isn't there? If the surgery is to remove the adrenal tumor that's causing the Cushing's, what happens when the tumor is out?
That's a fantastic point. The moment the surgeon ligates the venous supply from that tumor, the source of excess cortisol is gone. But the patient's other contralateral adrenal gland has been suppressed for months or years. It's atrophied.
So they go from a state of massive excess to profound deficiency in a matter of seconds.
Instantly. You have to anticipate this. You
Wow.
must begin steroid replacement therapy intraoperatively right after the tumor is removed to prevent them from crashing into an Addisonian crisis post-op.
Okay, time for the main event, the topic that makes or breaks careers in the Viva. Pheochromocytoma.
The great white whale of endocrine anesthesia, a catecholamine secreting tumor of the adrenal medulla.
And it comes with the rule of tens.
The classic rule of tens. About 10% are bilateral, 10% are extraadrenal, 10% are malignant, and 10% are familial, associated with syndromes like MEN2 or von Hippel-Lindau.
What's the clinical presentation?
The classic triad, and you must know this: paroxysmal headaches, sweating or diaphoresis, and palpitations or tachycardia. If you see that triad in a patient with hypertension, you must rule out a Pheo.
Let's dig into the pathophysiology. This is where the real understanding is tested. We know they have hypertension, but what is their intravascular volume status?
This is the single most important concept to master. Patients with a pheochromocytoma are volume contracted. They are profoundly hypovolemic.
It seems backward. How can you have sky-high blood pressure but be low on volume?
Imagine your entire vascular system is a garden hose. The tumor is pumping out massive amounts of norepinephrine, which is a powerful vasoconstrictor. It's like having a giant clamp squeezing down on the entire length of that hose.
Okay, so the pressure inside the hose is immense.
Immense. And because of that intense chronic vasoconstriction, the body responds by reducing the amount of plasma in the system. Fluid shifts out of the intravascular space, so the hose is squeezed tight, and it's also half empty.
And that's the setup for a catastrophe during induction of anesthesia.
Precisely, because what do nearly all of our anesthetic agents do? They cause vasodilation.
They release the plane.
They release the clamp. And if you suddenly release the clamp on a half-empty hose, the pressure drops to zero. That's the mechanism for the profound catastrophic hypotension you see after induction if the patient hasn't been properly prepared.
So preoperative preparation is not optional. It's mandatory.
It is the entire key to a successful outcome. You never, ever take an unprepared Pheo patient to the operating room. The Bible for this is Roizen's criteria for optimization.
But before we even get to the criteria, we have to talk about the drug sequence. This is the ultimate pass or fail question.
It is. There is no recovery from getting this wrong.
Yeah.
The question is simple. Do you start with an alpha blocker or a beta blocker?
And the answer is?
Alpha-Blockade. First, Always. A before B. You absolutely must block the alpha receptors before you even consider touching the beta receptors.
Let's walk through the pathophysiology of getting it wrong. I'm a junior resident. I see the patient has a heart rate of 130, and I give a beta blocker like metoprolol. What happens next?
Catastrophe. You've blocked the beta-1 receptors in the heart, so you've taken away its ability to beat fast and hard. You've also blocked the beta-2 receptors in the peripheral vasculature, which are responsible for vasodilation.
Okay.
But you've left the alpha-1 receptors completely unopposed. The circulating norepinephrine and epinephrine from the tumor now have only one place to go. They slam onto those alpha receptors, causing the most intense, unbelievable vasoconstriction you've ever seen. The systemic vascular resistance goes to infinity.
And the heart, which I've just crippled with a beta blocker,
Cannot possibly pump against that afterload. The patient goes into acute left ventricular failure and flash pulmonary edema. You will kill the patient on the ward. A before B.
Okay, message received. So we start with an alpha blocker. What's the classic drug?
The classic agent is phenoxybenzamine. It's a non-selective, long-acting, irreversible alpha blocker. It forms a covalent bond with the receptor. It's a bit of a dirty drug, but it provides a very profound and stable blockade.
Are there newer options?
Yes. More selective alpha-1 blockers like prazosin or boxazocin are used now. They are competitive antagonists, so they're shorter acting and can be overcome. They tend to cause less post-operative hypotension. You should know both.
And how do we know when the alpha blockade is adequate? When is the patient ready for surgery?
You're looking for specific clinical signs. We follow Roizen's criteria. The blood pressure should be controlled, ideally less than 160/90. They should have no new ECG changes for at least a week. And importantly, they should exhibit mild orthostatic hypotension.
So a drop in blood pressure when they stand up tells you the blockade is working.
Yes, it means their vessels aren't clamping down reflexively anymore. They are relaxed. Once you have that, you begin volume expansion. You start loading them with IV fluids to fill that newly expanded vascular space.
And only then, if they're still tachycardic.
Only then do you cautiously add a beta blocker.
Right. So the patient is finally optimized. We're in the OR. This surgery is famously a roller coaster.
It's a tale of two phases. Phase 1 is everything up to tumor removal. We can call that the storm. Phase 2 is what happens right after the tumor's vein is ligated. That's the crash.
Let's talk about the storm. Induction, intubation, and surgical manipulation of the tumor.
All of these things can trigger a massive release of catecholamines from the tumor, causing a severe hypertensive crisis. Your goals are a deep, smooth induction and avoiding any drugs that release histamine, like atracurium or morphine.
And you need to have your rescue drugs drawn up and ready.
Absolutely. On a dedicated IV line. The classic is sodium nitroprusside, or SNP. It's a direct vasodilator, very powerful, with an immediate onset and offset. Phentolamine, an alpha blocker, is another great choice. Magnesium sulfate is also fantastic because it inhibits catecholamine release and acts as a vasodilator.
Okay, so you've weathered the storm. The surgeon has dissected out the tumor and shouts, "Vein is clamped." What happens now?
Now comes the crash. The tap of catecholamines has just been turned off completely, but the patient is still fully alpha blocked from the preoperative medication.
So their blood pressure is going to plummet.
It will fall off a cliff. Your first move is to stop all your vasodilators immediately. The second is to give a massive fluid bolus, and you'll almost certainly need to start a vasopressor infusion like norepinephrine or phenylephrine to support the pressure until that alpha blockade starts to wear off.
And post-operatively in the ICU, there's a crucial metabolic derangement to watch for.
Yes, hypoglycemia.
Why does that happen?
The high levels of catecholamines from the tumor suppress insulin release from the pancreas. The moment the tumor is out, that suppression is gone. The pancreas wakes up and often releases a huge surge of insulin, which can cause profound hypoglycemia. You have to check blood glucose levels frequently in the first 24 hours.
Brilliant. Let's quickly cover a few other related conditions. Conn syndrome.
Primary hyperaldosteronism. This is a tumor of the zona glomerulosa. Too much aldosterone.
So hypertension from sodium and water retention. And what about potassium?
Profound hypokalemia. The aldosterone causes the kidneys to waste potassium. The main anesthetic challenge here is managing that hypokalemia preoperatively to prevent cardiac arrhythmias and potentiation of muscle relaxants. The drug they'll be on is spironolactone.
What about an adrenal incidentaloma?
That's a mass found on an imaging scan done for another reason. The golden rule is you must treat any adrenal mass as a functional tumor, specifically a Pheo, until proven otherwise. Never let a surgeon operate on an incidentaloma until the patient has had a full endocrine workup, including plasma or urine metanephrines.
Let's touch on congenital adrenal hyperplasia, CAH.
This is a beautiful physiological concept. It's a group of genetic disorders where there's an enzyme defect in the cortisol synthesis pathway. The most common is 21-hydroxylase deficiency.
So the adrenal gland can't make cortisol or aldosterone.
Correct. The factory line is broken at that step. All the precursor molecules, like cholesterol, pile up behind the block and get shunted over into the only remaining pathway, the androgen pathway.
So the clinical picture is a lack of cortisol and aldosterone, leading to salt wasting and adrenal crisis, but an excess of androgens, causing virilization.
Precisely. And for us, the take-home is simple. These patients are cortisol deficient. They need stress dose steroids for surgery.
What about the surgery itself? Adrenalectomy, laparoscopic versus open.
Laparoscopic is the gold standard for most benign tumors, but it has its own challenges, especially for a Pheo. The insufflation of carbon dioxide to create the pneumoperitoneum raises intra-abdominal pressure. This can squeeze the tumor and cause a catecholamine surge before the surgeon has even touched it.
So you have to be ready for a hypertensive crisis right from the start of the case.
You do. Open surgery is reserved for very large or potentially malignant tumors. It's a bigger operation, more pain, but can sometimes offer more controlled dissection.
And finally, let's bring it to the ICU, the concept of CRCI.
Critical illness-related corticosteroid insufficiency. This is the idea that in severe prolonged stress like septic shock, the HPA axis can become exhausted or the body's tissues become resistant to cortisol's effects.
And we suspect this in vasopressor refractory shock.
Exactly. The patient is on high doses of norepinephrine, maybe even a second pressor, and their blood pressure is still poor. This is when you consider a trial of low-dose hydrocortisone, usually 200 milligrams a day. It can often dramatically improve their hemodynamics.
Right. We're at the end of the exam. The examiner says, summarize for me. Draw me a table comparing these conditions.
Simple and high yield. For Addison's versus Cushing's, Addison's is low BP, low sodium, low sugar, high potassium, think dry and brown. Cushing's is the opposite. High BP, high sugar, low potassium, think wet and round.
And for Pheochromocytoma versus regular essential hypertension.
Essential hypertension is typically sustained, and they don't have orthostasis. A Pheo has paroxysmal spikes of hypertension and, crucially, severe orthostatic hypotension because they are volume contracted.
Final round. The Viva traps. The instant fail answers. Give me the top three.
Number 1, giving a beta blocker before an alpha blocker in a Pheo. Unforgivable. Number 2, using etomidate in a septic patient or someone with known adrenal issues. And number 3, forgetting about the risk of hypoglycemia after a pheochromocytoma resection.
And what are the safe phrases that show you're a thoughtful candidate?
My priority would be thorough preoperative optimization. I would have a high index of suspicion for HPA axis suppression in any patient with a history of steroid use. I would ensure I have invasive arterial monitoring and large bore IV access before induction.
For the written paper, you'd want to draw diagrams.
Absolutely. Draw the HPA axis feedback loop. Draw a simple flowchart for managing a hypertensive crisis intra-op, and another for managing sudden hypotension after tumor ligation. It shows you think in algorithms.
This has been an incredible simulation. Let's give our candidate the take-home summary.
It comes down to this. Adrenal physiology dictates the entire stress response. If a hormone is missing, like cortisol in Addison's, you must replace it. If a hormone is in excess, like catecholamines in a Pheo, you must block it, but you have to do it in the right order. Respect the physiology, anticipate the crisis, and you'll master this topic.
The adrenal gland, the anesthetist's best friend in stress and worst enemy in disease.
Couldn't have said it better myself. Now go ace that exam,
Yeah,
and always check the potassium.
We'll see you on the next rotation. This is The Deep Dive, signing off.